Bismillah ar-Rahman ar-Rahim. Good evening, everyone. On behalf of the Saudi Heart Rhythm Society, I would like to welcome all of you for our in our live webinar. And it's a series of teaching webinars that we are doing in the Saudi Heart Rhythm that covers very interesting topics. And today we are gonna focus on two very challenging topics. One is cryo ablation for persistent AFib patients. And the second topic will be advancement in remote monitoring for our patients in this COVID era, which is a very difficult time in our lives, where we always ask patients to stay at home. How are we caring for them and advancement in this field? And joining me today in the as a panelist, we have Dr. Naeem Al-Shaibi, the president of the Saudi Heart Rhythm Society, consultant cardiac electrophysiology, King Abdulaziz University Hospital in Jeddah. We have Dr. Ala Al-Dosari, consultant cardiology and electrophysiology at King Salman Heart Center in Riyadh, and Dr. Musa Al-Harbi, who is a consultant electrophysiologist at King Fahd Specialist Hospital in Dammam. We have our esteemed speakers who will cover these two topics. We have Prof. Serge Boveda from Clinique Pasteur, Toulouse, France, and Prof. Pascal Defay from CHU Grenoble Alpes, France, and Dr. Sophia Jones, principal cardiac scientist at St. Bart's Hospital in London, and Dr. Ahmed Al-Faqih, our senior cardiac electrophysiologist and the head of EP at Prince Sultan Cardiac Center, Riyadh. One note to our attendee, please ask relevant questions to the topics, because we don't want to be slammed with many questions that are completely irrelevant, because we will select, we have very few time between lectures to select the most important and most relevant questions. And we will ask these questions and answer them. I hope all of you will enjoy our lectures today, and we'll start with Prof. Serge Boveda, who will will show us a video of the procedure cryo ablation for persistent AFib patient. Prof. Serge, the mic is all yours.
Thank you very much, Dr. Atif. Salam from France. I hope that everybody is doing well in this difficult situation. I really want to thank you for offering us the opportunity to share with you our experience about cryoablation of persistent atrial fibrillation. And for that, I would like to share with you a video that we have prepared a few years ago. And I will share my screen with you right now, and I will show you the video. Of course, this video will be cut a little bit because it's a little bit long, but I will try to go through the most important steps. The first thing is that we have started cryoablation of persistent AFib about 6 or 7 years ago. And as you will see, we are performing the atrial fibrillation we are performing the ablation during atrial fibrillation, not in sinus rhythm, for many reasons. And one of these reasons is that we like to see the activity of the pulmonary veins during the ablation, because it can give us very important information. So we will start the video by the Transceptor Puncher, and I will show you very simply, very quickly, the Transceptor Puncher, which you will see here. So we have a very simple technique of Transceptor Puncher. For the little history, I learned to do the Transceptor in Tunisia, in the La Rapta Hospital of Tunis, because they are doing a lot of mitral valvuloplasty there. And in the 90s, I went in this hospital to learn a Transceptor Puncher. And this is exactly the same technique that I'm using every day for going through the septum. So you can see that we are only two introducers, one with 4 polyps that we place in the CS, in the coronary sinus, to give landmarks, anatomical landmarks. And we place an SL0 sheath just beside the coronary sinus. We are placing the needle inside the sheath, and you will see I'm using only the contrast to see where is the septum. I will show you right now. So we are using a little syringe of 10 cc with a dye here that we fix on the needle. Then, as you probably do the same, we are in AP, we are going lower with the septum and the sheath. You can see on the right panel. Then we have a small jump here right now. I hope you can see the video quite well. Now we go to RAO, so right anterior, and we see the movements of the sheath and the coronary sinus lead, the CS lead. You see that it's moving at the same time. It's synchronized. That means that you are really in contact with the septum. Then we go in LAO, and I push the needle while injecting at the same time, and you will see slowly the tenting of the septum here. You will see the contrast that is appearing a little bit now, but it will be better in a few seconds. So at the same time I'm pushing the needle, I am injecting the contrast, and you will see here, you see the patch. This is the septum. I went through with the needle. Now the needle is on the inside the left atrium, and now I'm pushing the dilator. Now the dilator is in the left atrium, and now I will go with the sheath. This technique is good because you can know exactly, you can monitor at the same time visually where is the sheath exactly, and preventing to go backward with a transeptal sheath. So now the sheath is okay. Now the sheath is in the left atrium. We are in LAO. Now I will show you in a few seconds the sheath exchange, because of course we're using a different sheath for the cryo ablation. You can see that the first thing that is very important to do is go with a wire inside the pulmonary vein, the left superior pulmonary vein, to get a security when you're going through the septum with a sheath. Now we are taking out the SL0. We are taking out the SL0, and we are going with a flex cut with this, which is a specific sheath from Medtronic that we are using for the cryo balloon. So this sheath is very helpful because it's steerable, but while you're going through the septum, you can see the small rotation movements. While we are going through the septum, the sheath remains straight, because of course, if you are steering the sheath now, removing the sheath, you will go out from the vein. So now we will push a little bit the sheath. This is a 15 French diameter sheath. This is why we are not doing the transeptal in first intention with this sheath. Now the sheath is inside the left atrium, and now we will go in the left superior pulmonary vein with the sheath ready for the first application. So I will move forward now directly for the left superior pulmonary vein ablation. You can see, if I go to minute 10, okay, this is a CT scan that we are doing before all ablations, because it gives you the information of the anatomy of the left atrium. Is it a common trunk? Is it an additional vein? In this patient, everything is normal. You have 4 veins, they are completely normal. So this is a normal anatomy. So we'll move to the left superior pulmonary vein. We will place first the Achieve, which is a special design catheter in order to map the PV potentials. We use the Sheath, which is a very smart catheter, first like a guide wire in order to go inside the vein. Then, as you will see, we are moving a little bit inside. Okay, this is the Sheath catheter. I don't know if you saw it. Maybe I go back to show you better. Okay, this is the Sheath catheter. You can see it's like a lasso, but it's very soft. The tip from here to here is extremely soft, like a guide wire. So it's really very safe for the patient. We can use it like a guide wire inside the vein. But in addition with the electrodes, you can map at the same time the pulmonary vein, as you already know, because I know that you are doing cryo in Saudi. So you can see that inside the vein, you can see the PV potentials. You can see that this vein is quite active. So this is one of the information we like to have during ablation. It gives you the activity of the vein. Is it bystander? Is it really bursting or not? In this case, it's quite active, not really bursting, but it's quite active. Then we move the balloon a little bit inside at the ostium of the vein. You can see the bronchia here. So this is the roof of the left atrium. This is already the vein. We will inflate the balloon right now. So we will inflate in a few seconds. The balloon here, you will see. Okay, now the balloon is inflated. I hope you see it in the video. And then you will see that the Sheath catheter is moved back to the balloon in order to get better PV signals. And you can see on the lower panel on left, you can see the PV signals during ablation. This is very important because it will give you exactly the time of the disconnection of the vein. So first we inject the contrast to see the occlusion of the vein. You can see that there is a leak on the bottom of the vein here. So we move a little bit better the balloon. We are pushing a little bit more with the sheath. And you can see that here, the occlusion of the vein is good. Is good. It's good enough to do the first application. So we'll do the first application here. You can see that the occlusion is really nice now. So we are beginning on the left upper panel. You can see that we are beginning the cryo ablation. You can see the temperature that is going down, 5 degrees, 0 degrees, -1. And you can see at the same time the PV potentials on the lower panel. Now in the middle, you can see that we have an increasing of the cycle length while we are freezing the vein. And you can see that like little by little, we are separating the PV potentials more and more until it disappears. And now you can say that you have a PV disconnection of the left superior pulmonary vein. So in this case, we could disconnect this pulmonary vein in about 1 minute. Let's go back to the console. Okay, you can see we have here more than 3 minutes of cryo, -60 degrees. And this is the end of the application, of the cryo application. So this vein is done. We are going to the left inferior. We are moving, steering a little bit the sheath. Again, the sheath is going first inside the vein. We'll push the sheath here. Okay, now the sheath is inside the left inferior. We are working in AP, anterior posterior. We are withdrawing a little bit the sheath and we will inflate the balloon again. We will use, like in mostly the left inferior veins, the hockey stick positioning of the sheath. You will see that I will push a little bit the sheath upper to the roof of the left atrium. You see I'm moving to the roof. Then I will inject the contrast. Again, injecting the contrast. to assess the occlusion of the vein. Okay, you see that it's not perfect. So we'll improve a little bit. And then we go, you see the hockey stick here, and we go for the second application, cryo application, this time in the left inferior. And you can see again the PV potentials, and while freezing at the same time, you will see that the cycle length of the PV potential will increase little by little. You can see now in the lower panel, the increasing of the cycle length, more, still there, a little bit, still there, and it's gone. So here you can say, here you have a last one, but you can say that now you have a disconnection of the left inferior pulmonary vein. We will finish with the right inferior and the right superior. The procedure is the same. For the right veins, you know that we need to pace the phrenic nerve in order to prevent phrenic nerve palsy. So we pace at the junction between the SVC and the subclavian vein. And you can see that we can assess the diaphragm contraction while ablating at the same time in order to prevent any damage from the phrenic nerve. So we will go to the right inferior pulmonary vein, still maybe 2 or 3 minutes of video, and then I'm done. Okay, we will go with a Sheath catheter inside the right inferior. Then we will inflate the balloon. You can see that the balloon is inflated here. The Sheath is inside the vein. You can see that the PV potentials are there again. Very nice, very sharp, quite quick, not very quick, but quite quick. And we can check the occlusion by injecting the contrast. I will show you right now the contrast injection. Okay, now you have the contrast. You can see that there is a good occlusion of the right inferior, and we are starting cryo right now. You will see when it's green. Now it's green. So we are starting cryo, and while the cryo is beginning, 7 degrees, 3 degrees, 1, -4. You can see at the same time the PV potentials that are separating, and in this vein are gone again. This is artifacts that are due to the fact that the Sheath catheter is very close to the balloon, and after disconnection you have a nice formation that is provoking a little bit artifacts, but it's not a big problem. It's not a problem at all, in fact, because the vein is already disconnected. And we will finish with the right superior. You will see now positioning of the Sheath catheter in the right superior, far inside, like a guide wire, inflating the balloon. Now the balloon is inflating at the ostium of the vein. You can see the silhouette of the heart. Balloon is inflated at the ostium. We will inject the contrast to assess the PV occlusion. You can see that the PV occlusion is quite nice here. Little, it's okay. And we start freezing. And you can see again the PV potentials here that are moving, and they are gone. So the 4 veins are disconnected in this patient. The next step at the end of the procedure is to restore sinus rhythm thanks to electrical cardioversion. I will show you right now. Okay, you will see now you see the cardioversion here, and now the patient is in sinus rhythm. Okay, so now the thing is to follow the patient. We put under antiarrhythmic drugs, yes or no. This is something that we can discuss, and this is what I wanted, mainly the things that I wanted to share with you with this cryo ablation video. Thank you very much.
Thank you, Dr. Serge. I'll leave the questions for this session till the end after Dr. Pascal, and the questions will be for both of you. So now we'll thank you for this elegant video and challenging case. We always find the persistent AFib more challenging than paroxysmal in our practice. But and now Dr. Pascal, Prof. Pascal Defay will show us few slides how to tackle such interesting case. Prof. Pascal?
Yes, of course. So thank you very much. Thank you very much, dear Chairman, ladies and gentlemen. I will share with you some slides concerning cryo ablation of persistent AF. I will share my screen. Okay. Okay, you can see my screen?
Yes, we can.
Yes. Okay. So in my center, as Serge said, I began cryo ablation in 2007, and we perform more than 2,800 cryo ablation and more persistent AF now. So I began 13 years ago cryo ablation. And I would say I would focus on the reproducibility of cryoballoon-based PV isolation. In this slide, you can see it's a paper from Providencia, Serge Boveda and me, and we compared cryoablation and RF in some European centers. And you can see that, in fact, whatever the hospital, whatever the physician, this technique is much more reproducible than radiofrequency among centers. And we can see that we can say that cryoballoon seems to be less operator dependent and more reproducible than RF in the setting of paroxysmal AF ablation. So it's a short learning curve and reproducible clinical outcomes. And you can see there that in the cryoballoon center, we have some very low volume center, and you can see that some centers have a very few number of cryoballoon per year, and we can say that a system is only as good as its reproducibility is in less experienced hands. And even with low volume center, we have very good results, and we have the same result whatever other centers. Why we have good results with cryoballoon for ablation of persistent AF? Because cryoablation is an ablation more than pure PV isolation. And due to the mismatch of the 28 millimeter cryoballoon and the PV size, about 40 to 50% of the posterior wall is ablated in normal size left atrium. So we can say that cryoablation is a substrate modulation. And I will also share with you some results of the cryo for persistent AF trial. We conducted this trial with Serge Boveda. This trial was published in JACIP in 2018. And concerning the results of cryoballoon ablation of persistent AF, only with PV isolation, we have 60% of excellent results, freedom for all arrhythmia at 12 months. So for us, it's a very good result, not excellent, but as good as RF. We use only PVI in this study, and all repeat ablation were failure, inclusive of blanking period. We can say also that around 5% of the patients are under antiarrhythmic drug in sinus results, so it's very few. And concerning safety, we have very few major events, only one pericardial effusion, and he was treated medically, no deaths, of course. I will add just 2 slides. We can also, although it's off-label, we can also perform the roof line with cryoablation. The roof line can be performed with RF, but can be performed very easily with cryo. And in this study, it's a German study, it seems to be even more effective to perform cryoballoon roof lines than RF, and the results are better when we add the roof line with cryoballoons than with radiofrequency. And the results with this study of cryoballoon plus roof line is around 80% of success at 36 months. It's excellent. And some teams also add left atrium, left appendage isolation during this ablation, and we can also improve the results of PVI isolation. It's also off-label with PVI plus LA isolation, and it's relatively easy to perform appendage isolation, left appendage isolation with cryoballoon. So it's finished for my slide. I think we have time to discuss and to debate.
So thank you very much, Dr. Defay, and I'll leave the floor now to Dr. Musa Al-Harbi, who will ask a couple of questions about this great topic.
Okay, thank you, Prof. Sergio and Prof. Pascal, for this elegant talk. To Prof. Sergio, just a few questions. Is it a must to have a CT before a cryoballoon, or would you replace that with a different imaging tool like an ICE catheter and utilize it to isolate the vein?
Mm-hmm. Thank you. This is a very, very good question. I completely agree. To be honest with you, I really think that to have previous imaging before putting the catheters inside is good. It's good because it's like having the anatomy before the procedure. It prepares you in your mind to know exactly which movements you will have to do. Will you have to look for a common trunk or not? Will you have to look for an additional vein or not? The ICE is different. I agree that the ICE is maybe interesting for proving the occlusion of the vein. It's interesting for the transceptor, I agree, but it's different. It's not the same question. For me, the previous imaging, the CT scan before, it's like when you taking your Google map to go from Riyadh to Jeddah, for example, you know exactly which road you have to take, at what time you will have to go from your home, at what time you will arrive. The mapping, the CT scan before the ablation is like a mapping, you know, it gives you a lot of information that prepares the procedure, and for me it's good. It's good also when you have less experience because it can be helpful for safety questions, etc., etc. For me, it's something that I'm doing since the beginning. I start like Professor Pascal, the ablation, cryoablation, many years ago when I was younger, and I was starting with the CT scan. I still doing the CT scan because for me it's important.
Yeah, exactly same for me. Exactly the same for me.
What about the time of cryo application? Would you go with 2 minutes? Would you go with 4 minutes? What's the idea?
Okay, another important question. Thank you. As you know, historically, the timing was 4 minutes 2 times. We moved to only one application, no bonus application, when you had a disconnection, when you have a disconnection of less than 1 minute. So this is what we are doing now. We moved with my friends from Brussels to 3 minutes. But you will see in the JACIP a paper from the team of Frankfurt of Yonggi Chun, who proved that in the patients that have a recurrence of AFib, the patients with 3 minutes application have more PV reconnected than the patients with 4 minutes application. This is why I came back to 4 minutes after ablating during 2 or 3 years with 3 minutes application. Since 1 or 2 years, I came back to 4 minutes. And the editorial of this this journal, where you have this article, is Back to the Future, because I wanted to say that first it was 4 minutes, then 3 minutes, and now again 4 minutes, because I believe that the disconnection has maybe a better quality. So this is my advice.
Okay.
4 minutes.
Yes, I have the same advice. I maintain 4 minutes in my center, except sometimes for the right vein, when the temperature is too low to avoid a phrenic palsy. But usually we use a 4-minute application one time.
So Prof. Pascal, since you mentioned the right pulmonary vein, would you be worried if you get isolation immediately within a few seconds of cryo application? Would you be worried that you're too deep? You would be worried about injury of the phrenic nerve?
No, I just look on the temperature, because we ablate only on the ostium, and I verify that the shape of the balloon is okay. I don't introduce the balloon, of course, inside the vein. It's very difficult with a 28mm balloon. It's impossible. So we are very ostial, and I check the temperature. If you are very ostial, the temperature usually is around -40, -45, not less than -45 usually.
You see. Now, what about doing redo?
Thank you very much.
Just another quick question about redo AFib ablation after cryo. Would you go again with the cryo? Would you go with RF to just better understanding of the substrate?
It depends. It depends of the patient. Sometimes, for not long-term persistent AF, for short persistence, less than 6 months, we can do redo, but we perform more than PVI. We perform the roof line, and we perform the left atrial appendage occlusion also. But it depends. I think that Serge in his center, in case of redo, he moved to RF. In my center, it's not mandatory. It depends.
Mohsen Atif, would you enlighten me? That's for just last question.
Yes, thank you.
So so you said that you do the CT for all your patients. So once you get the CT report or the CT image, what is the consideration in your mind? You say maybe it will be a difficult case. Maybe I'm going to use RFA this time rather than cryo, or do you use cryo for everyone? What is the thing that let you think twice about cryo?
No, we use in my center in the first attempt we use cryo for everyone. We don't choose a patient depending of the CT scan. The CT scan, as said by Serge, it's only the map to know if there is a common thumb, to know if there are additional veins. It's very useful to simplify the procedure, but it's not a tool to choose the energy. We begin with cryo, but we don't choose with the CT scan.
Thank you. I just want to add a very small thing that I think it's important. I go for cryo when I want to do PV isolation. For me, the cryo is the best tool for performing PV isolation because it's homogeneous, it's one shot, it's simple, it's safe, and it works very well. The duration of the lesions is very good. So when I go for PV isolation, I take the cryo. When I go for something else, when I have in mind, for example, in a redo patient that you were saying before, the bad news with the cryo, if I may say, is that the lesion is very good. So you may come with already disconnected veins. So you have to think about something else. And in this case, for the redos, I prefer to move to radiofrequency. When I have an idea of, for example, a micro-entrant circuit or a trigger that I want to tackle, I will go more for radiofrequency. But when I go for PV isolation, for me, cryo is the first intention because it works really very well. And as was saying Professor Pascal, the only use of the CT scan is not to select the patient, is just to guide the procedure, not to select.
Okay, thank you very much, Prof. Pascal and Prof. Serge, for this great talks. We really enjoyed it. And now we will shift the gear a little bit and move to Dr. Sophia Jones to talk to us about the advancement in patient remote monitoring, remote management in post-COVID era.
Hi, I'll share my screen. Thanks for the invite, and thanks for allowing me the opportunity to share my experiences and celebrate my team and my hospital for doing some amazing work during this pandemic and utilizing some fantastic technology from all different kinds of companies. So I hope I can enlighten you in what we're doing. Can you see my screen?
Yes, we can.
Brilliant. So I'll start by giving a background to device management at Barts. So at Barts Hospital.
Dr. Sophia, can you open your video while you're talking?
Oh, yeah, sure. Okay, great. So yeah, at Barts Health we have 5 hospital sites within the trust, and St Bartholomew's provides the main bulk of device management, and we do a 24-hour emergency device service and VT ablation service. We also provide 24-hour emergency remote follow-up service as well, which is quite unique to the UK, I believe. Routine device clinic with face-to-face follow-up used to see about 100 patients a day, which is quite sizable. And that's changed now. We have over 18,000 active patients in device follow-up clinic, and we have been running 3 cath labs during the pandemic period for urgent devices. So it keeps going up, never ends. With Medtronic ILRs, you can see in the graphs how many ILRs we've implanted since 2018, 19, and 20. So it's gone up quite considerably, and we're projecting to do even more once we've sorted everything out with the pandemic. We do about 8 to 10 patients per day in an outpatient setting for ILR. So that's the highest number of implants in London that we definitely know at the moment. And then overall at Barts Health, we implant, you can see in the other graph, between 2018, 17 and 19, how many implants we're implanting per year. So it's quite a sizable clinic, and all of these patients are pretty much followed up at Barts. So it's big. So the challenges were high volume of face-to-face and remote follow-up device checks. We had difficulty with staff recruitment and retention. It's quite a specific profession with specific skills, and you get basic training in cardiac diagnostics and cardiology, and then you specialize within devices and EP. So getting these skilled members of staff is quite difficult, and retaining them with this workload you have to face and all the other constraints of work and life balance is challenging. There's a significant need for training and development, so you can't just put people on the work all the time. They want to develop, they want to train, they want to progress in other areas. And it's imperative that the quality of care and efficiencies are maintained. So we need to manage the workload but deliver high quality services. So as we grow, it's constantly a challenge. So this is our staffing in a stick person's way of showing it. And we've adapted over time to try and make ourselves more efficient. So we have 24 arrhythmia staff members with varying skill mix, and not everybody is competent to do everything. And they have to cover 5 sites on a daily basis. 14 are currently in training with their roles at least 3 times a week. So there's the burden of training as well as delivering the work. We have to reallocate staffing, and we've tried to upskill lower bands so that we've got a bigger pool of people to deliver this care to patients, and trying to give specialist device clinic opportunities for things like VT patients, grown-up congenital patients, so having a specific clinic to deliver care to them. So it's trying to put 24 people in a million places all at once, so it's very, very difficult. And one of the benefits, one of the good things that we did to try and help this workload was introduce Focus On from Medtronic to manage our ILR follow-ups. We were getting a lot of downloads a day, and to try and keep up with that workload was really difficult. So we've put our more junior physiologists to look after that service with the help of the Focus On service as well. So Focus On, we did a trial in April 2018. We put 371 patients on there. And this is what we did. So in total now there's 936, and all of our patients are now automatically enrolled onto Focus On. There were 23,242 transmissions in 2018 up to now, and 1.4 average working hours to report red events. So we now have cut down our workload because we're only looking at the red and amber events that come through, which is the things that we need to see. Anything that's normal sinus rhythm or anything that's not needing to be escalated, we don't have to look at. So that's significantly reduced our workload, which is amazing. So I'll talk through our remote management before, and then I can show you what we're doing now. So before, we only put our high power devices on, so CRTDs and ICDs, and then our ILRs. And links are now all on Focus On as of April 2018, which is great. CareLink is used alongside other manufacturers, so we implant all the manufacturers of the devices available here at BART, so we've got multiple websites and multiple services to use. The remote clinic runs 7 days a week, with the weekends being alert based. And there's at least 4 people every day looking at remote follow-ups, Monday to Friday, 8 till 6. So it's quite a sizable clinic before. In outpatients, we see our low voltage devices, so pacemakers, CRTPs, and they're reliant on the face-to-face follow-up. They don't have remote monitoring. We have 6 clinic rooms per day and over 100 patients per day. And we had the desire to convert our low voltage devices over to remote monitoring, but there was limited national and European guidance to support it. So we didn't really feel comfortable doing that with the little evidence that we had. Then COVID happened, and the BHRS, the British Heart Rhythm Society, recommended we use remote monitoring as much as possible to try and protect patients from transmissions and having to travel. And a lot of our pacemaker patients and CRTP patients are within the high risk group, so over 70 with comorbidities that put them at risk of significant harm if they caught COVID. So we had to change a lot of things. We had to split the team up for resilience, so to make sure that not everyone was on site and everyone was at risk of catching the disease at the same time. We had to make sure we had a balance of skill mix so that people on site were trained to deliver the things that we needed on site. And we were lucky enough to expedite working from home. So we were able to do remote downloads from home, which is really good for the work-life balance and the anxiety around the pandemic for the staff. We were able to put our high-risk patients and low-voltage devices on remote monitoring, which was a really good support from the Trust. So it's a significant increase in the amount of patients we follow up in that remote clinic. We had to change workflows to comply with infection control. So we had to look at the equipment we were using. We had to look at the patients that we were going to implant. We had to categorize them, triage them, make sure they were urgent only. We did work from home, and we had to reschedule all our clinics. All the 100 patients that were planning to come in, we had to actively, as the cardiac scientists, reschedule them all, triage them, give them home monitors, communicate with them, reassure them, and rebook their appointment. So it was quite a busy time for us. And there was also the idea of a flying squad. So BARTs were key players in the response to COVID, and we were asked by the NHS London to consider delivering emergency pacing services for North East London at least. And that wouldn't necessarily be delivered on our hospital site. We might have to go to the sites with the patients if transferring was a challenge. So one of our lead consultants worked with us to prepare a flying squad. So we had to look at the stock that we were using, what devices would we take, are the programmers fit to chuck in a taxi and carry over? So the smaller the better, the easier to use the better. We had to make sure that they were Bluetooth or RF devices, because you don't know the environment you're working in and the space you have to implant these devices. We had to check the staffing and what did we need, and as if we could work as lean as possible, the better. So a nurse, a consultant and a physiologist. And then transport, how would we get there? And Northeast London is quite large if you have to get somewhere really quickly. So how would we get there? And then infection control, making sure we had the right level of PPE and everything was in order to keep our staff safe and the patients safe, and the taxi driver if we had to get a taxi. So Blue Sync technology was really useful. The tablet is small, easy to take around. The Bluetooth is great to use with the devices, no matter what environment you're in. And then the benefit we found as well was the MyCareLink app. So wherever we had to go, the patients could then use the app to do the remote monitoring. And we didn't have to take the other remote monitoring devices, which are quite sizable, and give these patients in an emergency situation all this information about remote follow-up. It's easy, it's on an app, it connects to your device. So Medtronic had some really good technology that we could use at the time of the pandemic and with the flying squad in mind. So we had to adapt, and as I said, the old one is quite chunky, it's difficult to clean, you have to be quite close to the table and the operator in the cath lab to connect everything up. So social distancing was a challenge. And we have them in each cath lab. It's very difficult to move things around with the environment you work in. And if you've got a big lab, you're great. If it's a small lab, then you've got constraints. So yeah, the new programmer is small, portable, light. You can stand further away. It's easier to clean. Yeah, so it was really, really useful in the pandemic. And we've got lifts in the hospital, I'm sure loads of hospitals have them, and to try and maintain social distancing and the queues that came out of the lift to try and get to any floors. If we had to go and do a post-implant check, or we had to get a programmer from somewhere else to use in the cath lab, it's going to cause a delay, and you have to carry it up. It's really heavy, a lot of stairs. So even a simple thing like being small enough so that you don't have to carry this huge thing and you don't have to wait for the lift was a massive help for us. And we work across the 5 sites, like I've said, so being able to...
Maintenant, tu sais, je me suis reconnecté, je vois les mecs. Attends.
So yeah, working on the 5 sites, being able to take this in a taxi or whatever, it's small enough, and go to wherever you're needed for that patient was really useful, rather than the big programmer that we normally have to work with. And yeah, what we found is a lot of our pacemaker patients and CRTPs were older population with lots of comorbidity. So we were worried about compliance with remote follow-up, which we were relying on for these patients, so they didn't have to come in. And, you know, disconnected monitors and all the non-compliance with patients takes up a lot of time. And it would have taken a physiologist, it did take a physiologist before, 5 days a week to try and get those numbers down. But with the different types of technology available from Medtronic, it was easier to tailor what would suit the patient, and the app is really, really useful. And in the UK, they did a study and found 55 people over 55, about, was it 75 or something % of people had got smartphones. So now that's more accessible to use the app, which is really useful. And we have found that more people are compliant with the app-based technology, less queries about connecting because it's all on an app and it's easy to see. Yeah, and we needed to make sure that everyone was connected and we could contact them and check on their device. A lot of our patients we converted to remote follow-up have no underlying rhythm. So we need to make sure that all their device checks are working fine. So it's good to make sure that they're connected to remote monitoring. So the different types of technologies was really, really helpful. We also used Be Connected, so we could pass the information on to the Be Connected team at Medtronic, and they can contact the patient, provide them support over the phone, help them set up their remote monitor. And that was really useful to take that away from the clinical staff that needs to go and do an emergency implant in the cath lab, for example. So all the services, not just the technology, was really, really helpful at this time. And then this is a slide, a summary about the app-based monitoring. And you can see it's really easy to see, and people have been able to check that they're connected with the green tick. They don't have to call us to say, is my monitor connected? And we found a lot of patients are quite anxious at home. They're used to seeing us in clinic, now they're not, and they just want to get that reassurance that we're connecting to their device. So that's really easy reassurance for them on the home page. And then there's loads of other things that they can access. So it was really, really useful. Yeah, this was it. So loads of people bought smartphones, which was really helpful to connect. And we kind of debunked the myth where maybe older patients don't like technology, and we found that that wasn't the case. And actually a lot of people have taken this up and really appreciated it and used it really well. So that was a massive positive for us. We were quite worried about that. So yeah, how can this help us? We're hoping that if patients have got this app or this technology and it's reassuring to them, then they can carry on with their lives and not be anxious about their device, as well as this pandemic that's happening and everything that has to change in their lives. We're hoping they'll be more engaged with their care. We're hoping that they will increase compliance, so we won't have the disconnected monitors, we won't have the non-attendance to the clinics. We hope that we'll get less transmissions that are unnecessary to the clinic, and patients will feel reassured that they're connecting with us when they need to, and not trying to send us loads of downloads because they're not sure if they're getting in touch with the clinic. And reassurance for the patients who normally used to come every 6 months or every 12 months, where we're trying not to do that anymore for their safety. So it's a little bridging the gap there with that technology. So the next steps, we're slowly getting back to a form of normal, but we're using this technology in Device Clinic to try and complement our service. We're trying to keep people out of hospital if they don't need to come, and only see people for things like programming changes, wound reviews, or significant issues. We're hoping to consider using Focus On, for example, with our other modality of devices, ICDs and pacemakers, because it's helping with the workload significantly. We are doing an audit ourselves to get the evidence base to increase our follow-ups for pacemakers. So we're working on that to provide evidence for others to take this on. And we're looking at capacity, we're looking at specialist clinics, we're looking at video conferencing for heart failure patients. So we're really looking at this technology and learning from others to try and improve the way we deliver care to our device patients. So in conclusion, Focus On was really, really useful for us, particularly because we're a high volume centre and limited capacity and workforce constraints. Technology is vital to deliver a device clinic service and successfully. And I think we were good at reacting to different ways of working, and we want to share this and learn from everyone else's experiences. And hopefully we'll all start gathering information for evidence-based care for using these technologies and extending appointments for Device Clinic to manage our workloads over time. Yeah, and that's it.
Thank you very much. This was a great talk and very comprehensive. And I think one of the things we learned from this COVID situation that many patients don't need to come to the hospital and can be managed remotely. I'll leave the floor now to Dr. Ala Dosri to fire a few questions, and before we move to our next talk.
Thank you, Dr. Safi, and thank you, Dr. Atif. Dr. Safi, it was a great presentation. Exactly, I would like just to highlight this, the positivity of Corona. It has given us the chance to go through the technical thing and to go through these application and new technique and virtual clinics to carry up and follow our patients. I have just a simple question through your experience, Dr. Sofia, regarding how did you manage to follow up your patient that they were not having a home monitor? How did you manage to bring them to the hospital during this pandemic event, and you went through probably better change or to check their devices? This is first question. The second question, which is patient that they come to ER for, let's say you need to go for urgent intervention, checking their devices or putting a pacemaker or BTAC, let's say ablation, and what is your steps during this pandemic time?
Okay, so let me check the first question. So if we had to bring people into the clinic, how did we plan for that? Is that what you're asking?
The non-monitored patient.
And home monitoring. So we had our list of patients ready to come, and we had a triage process. So we would look at their previous checks to see if there was anything abnormal with the device, any arrhythmias, any medications we needed to review. If everything was normal and stable, we would reschedule them to a 6-month or 12-month appointment, depending on the device. If they had no underlying rhythm or they were a CRTP, we would give them a home monitor, and we would send it to them in the post or through the Be Connected team and explain how to set it up from home. And then anyone with an abnormal device or an arrhythmia, then we would call them to make sure that they're okay. And in cases like low batteries, we would see them. There were some patients that had the 3-month ERI trigger, and we would give them a home monitor so that we can monitor them between the 3 months and the need to change. And any sudden depletions in battery, we would bring them in and do the box change. We had a low threshold to do box changes, so there were a lot of patients with a 2-month left, and we would change their boxes. We wouldn't wait until they got down to a lower battery level.
And regarding the patient that come to you in ER for emergency implantation or VTAC ablation, without any background, I know that there is a triage, but also from your experience, do you take the, let us say, the BPI, or what is your experience in such a case?
Yeah, so we will take a lot. We have a direct arrhythmia pathway, so if they're not within the Barts Trust, we can take them from other trusts, and we transfer the patients as an emergency to Barts and we implant them. We have a 24-hour on-call service, so if somebody needed an implant or a VT ablation, they would come in and straight into the cath lab and get that treatment. So there was no delay for emergency patients.
Thank you.
Can I ask,
Dr. Sophia? Yeah, Atif, go ahead.
Sorry, Naim. Can you tell us briefly about your 24-hour emergency service for the remote monitoring? This is a very nice experience that we don't have here in Saudi Arabia. If you can shed some light on that.
Yeah, sure. So we've got a physiologist who is looking at the remotes on a Saturday and a Sunday from 8 o'clock until 6 o'clock, and they're dealing with all the alerts that come through, and they're scheduled to do that. And then outside of that time, then the on-call physiologist overnight will periodically check the remote websites to see if there are any alerts through. And then if we do get anything, then we can either directly admit them through an emergency pathway, or we can contact the consultant of the week to review medications and deal with anything that needs to be dealt with over the weekend.
And if you feel that the patient is sick or something at 3 a.m., would you call 911?
Yeah, so yeah, direct arrhythmia, get them admitted. Yeah.
That's great.
Yeah.
Dr. Sophia, now we'll think of who owns the data. So now everyone believes that the patient should own his own data. So in terms of you giving those monitoring, how does the patient get access to his own data?
Yeah, so we're compliant with GDPR, and all the teams have gone through and made sure everything is right. And then if patients want to request their reports or their ECGs, then they can go through the requesting process in the hospital, and we can provide them with all their reports. And when they come to clinic, or if they request via email or telephone for a report, we can securely send it to them, so they can access it at any time.
Great. Thank you, Dr. Sophia, and we're very happy to have you with us.
Thanks for having me.
I'm going to move to Dr. Ahmed Al-Faqih, who will enlighten us about the local experience for remote management at King's Prince Sultan, at Prince Sultan Cardiac Center in Riyadh. Dr. Ahmed?
Yes. Thank you, Dr. Atif, and I don't know whether do you see my slides?
No, not yet. Now we do.
Yep, good. So good evening, everybody, and thanks for the organizers for this event. And I could see that the participants are more than 1,800 so far. And a special thank for Medtronic company as well, because of their extreme support during the COVID era. I'm talking about at least our center in the home monitoring issues. So they provided us with endless number of home monitors free of charge, with even focus on coverage. So everybody believes that the word is transferred digital, and among of you who are old enough have seen some of these programmers, and the younger electrophysiologists probably have seen some of these. And we are seeing this more and more now as the home monitors and the tablet-based programmers as well. Now, before I talk about our experience, the burden of the device check and the follow-up is really extreme. And it's a cumulative process. So in Europe, over the last 14 years, the number of implants has increased, almost doubled over the last 14 years, while the follow-up has increased almost 7 times. That's simply because you are accumulating your patients for follow-up. Whatever you are implanting 5 years ago, 7 years ago, 10 years ago is added to your last implanted year devices. In our center, to understand the situations that we are facing, in our center, we implanted over the last 10 years almost more than 4,000 devices in all kinds of devices, ICDs, pacemakers, CRTs, and ILRs. All of these devices has increased in numbers and almost doubled or tripled, or some of the devices has increased almost 7 times. And most of these devices really requires a home monitoring. And in last year only, 2019, we did more than 540 devices. Now, on the other hand, the burden of the device check and the device clinic over the last 10 years, we had a significant increase of the number from 2,700 patients to we reach almost 6,500 patients per year, in which a patient will spend 15 to 20 minutes in the clinic and he needs to be checked in the waiting area, he's traveling from far away, and so on and so on. So we found that we have to really work hard to reduce that. And we were able to do that. In 2019, we reduced almost 20% to 30% in our in-person visits and to the clinic. But still we do replicate whatever happened in Europe over the last 10 years, in which the last year only, the 2019, we had more than 12,000 transmitted data in addition to the in-hospital visits. So this is putting a lot of burden on physicians, on technical staff, on the nurses, on the hospital itself. So we thought about a solution for this. So we introduced the home monitor service and the remotely monitored a service somehow recently from 2015-16, but we got more adapted that in 2017-18 and more in 2019. We were able to reduce the number of the in-person visit to the clinic, and on the other hand, we increased our transmitted data in our device clinic. Now, if we go into 2019, we found that the 12 months throughout the year continue to have a steady number in the in-person visit, on average of 20-25 patients per day to 30 patients per day, and a consistent increase in number of transmitted data through the home monitoring system. Now, that's just to understand exactly what happened during this year because of the COVID-19. Now, especially in the beginning of the year, the last 5 months, January, February till May, that we had a significant reduction of the number of patients who presented to our device clinic because they cannot come simply because of the curfew and the lockdown. And on the other hand, there is a significant continuation and increase in the number of the transmitted data through the home monitor data. And in May and in June this month, the first 3 weeks only, we had more than 810 transmitted transmission, while only 30 patients in person visited the clinic. Now, if you go back to the last 3 years, comparing those 5 months, you found that consistent increase in the number of the transmitted data, a total of 378 transmission to 4,200 transmission. That helped us in dealing with the transmitted data in the COVID era. And as mentioned earlier Sophia that, as mentioned, the British Heart Society, Saudi Heart Society, Heart Rhythm Society indicated that every effort should be made to perform CIED interrogation via remote monitoring rather than in-person visit. And we know that the remote monitoring for CIED is more or less equivalent in terms of the information obtained, in terms of in regards to the arrhythmia, shocks, device function, and battery status. It can be as a scheduled intervals. You can give the appointment to the patient or to the device, basically, to get the interrogation, send the data, or can be triggered if any event happened, like shocks or a battery depletion or lead problem or fluid accumulation or so. But of course, does not provide any additional therapeutic capabilities. A lot of randomized control trials showed that the home monitoring is not is more or less the same as the in-person visit in terms of the ICD shocks, whether appropriate and inappropriate, the first hospitalization for the heart failure, and all-cause mortality as well. So the home monitoring is an excellent thing to adapt, but you should be able to know how to adapt it in an appropriate way. It's still a burden, as mentioned by Sophia earlier, that a lot of people are really involved in this. Unfortunately, we are still in the beginning in our center, in which we have just only minimal people who are dealing with from our side, probably one technician, maybe one or two physicians, and the rest of the electrophysiologist. So, and the coordinator to deal with the pathway of patients, getting the patients and so on. So to understand this, I'm going to talk about just only Medtronic because we have only Medtronic CareLink and Focus On. And to understand the idea of the Focus On, because probably a lot of audience has no idea about the Focus On service and how much it can add to the CareLink or to the home monitoring. Now, a patient has a device connected to the home monitor. This device can transmit the data to the hospital and get back to the patients with an action if there is any need for that by the hospital. But additional service can be provided by a third party to evaluate and triage any kind of data instead of bombarding the hospital by all of these data. So you get the data triaged and sent back to the hospital and giving the appropriate evaluation. That will give a free up time for the physicians and technical staff, expand access for the patients, so you can get more patients and so on, and enable better outcome, especially for the critically triggered events, and you can have a faster action and get a patient as soon as possible for any kind of intervention that you need to do so. Currently, we have the Focus On service only on Reveal Link, which is the ILR implantable loop recorder, but we don't have it yet on the devices yet. That is the Focus On, but the CareLink we do have a good number of devices. Now, in the Focus On, you can prioritize your findings, in which if a patient has a tachyarrhythmias or pulses, somebody will notify you within the first day by even phone call or email. And you can decide what kind of data that you need to be in the amber or a green, in which that they will notify you within the next working day or a next week or just during the week. Now, we do have the Focus On as other hospitals in the center in the country, and we comprise more than 65% of the Focus On CareLink of 60% in comparison to the other hospital. Now, on our virtual clinic, we have active patients during the 2015-2018. We have 222 patients active, out of them 99 in Focus On. Now, putting these numbers together, we need to know that these numbers are in which you start your year and a certain number, and you end up with a different number. For example, year 2019, we have an active patient of 305 and the focus on 136. This doesn't mean that in the middle of the year we don't have this number. It might be even more, but some people will be disconnected, some mortality, or a patient's being explanted, or so on and so. Then our transmission, average transmission time alert for the red as a third party from Medtronic as well. Now, during the 2020, we have active patient of 437, and the total patients that we have 437. The active patients were 331, and a focus on 126 patients with the same transmission time alert. Now, our indication for the reveal link is more or less the same as the other hospitals, with the cryptogenic stroke and syncope. Now, whenever a patient has a problem that's been transmitted to the hospital through the care link or the focus on, then an action has to be taken. This cascade of things has to go through the technical supports, from the hospital, the coordinations, the clinical pathway, basically. A patient has to be contacted by a coordinator, and the technician has to evaluate the transmission. A physician has to evaluate from the clinical point, and action needs to be taken. So this one has to be done within a short period of time, depend on how important is the thing. It's the same thing for the devices. For example, a patient has low pacing percentage in a CRT patient, or a patient needs a generator replacement, or you need to exit the patient because of the end of life of ILR, for example, or a patient with uncontrolled atrial fibrillation or inappropriate shocks, a patient who needs a ablation. So you need to deal with these things in a certain way and in a very fast manner. We replicate that during the era of the COVID as much as we can as well. Now, what happened during the era of COVID? As you know, that various forms of lockdown have been implemented by different countries just to minimize the spread of the COVID-19. And the social distancing and measurements were introduced in our country as early as March 2020. By the end of February, something around that. So that was happened gradually. So definitely this has affected a lot of hospitals in our area, including our hospital, and that we have seen it very clearly in our in-person visit in May, April, and March as well, and even during this month. And we try to look for the impact for the inactivity of heart failure patient because of the care view. Definitely they will stay home, and everybody is advised to stay home. Well, those patients with a heart failure, if they stay home, they will have minimal activity. Already they have low activity in general, but if they decrease their activity, they are at a worsened morbidity and mortality outcome, and the atrial arrhythmias and so on. Now, we try to look into our patients who are in heart failure, who had the capability of the care of the remote monitoring with complete data of 82 patients who had the CRT with the remote monitor. And we try to look for their activity during the COVID and how much the care view has really affected their activity. And we know that these kind of devices can give you very accurate physical activity per day, and because of these kind of accelerometers that built in these kind of devices, will tell you how much the patient is really moving during the 24 hours, and you can get a graph from these data. So we found that there is a real significant reduction in physical activity going exactly on the almost beginning of the care view on a partial social distancing, and getting worse and worse with the care view. not surprisingly, to have no significant change in the optimal fluid index and the thoracic impedance, because that was a bit short period. But we know that this significant decline in the physical activity might result in worse outcome, because all studies showed that if the heart failure patients get less activity, get more worse outcome. So therefore, we try to contact all our patients to advise them to get more exercise, even at home if they can, to improve their outcome. And I hope that they will do well or better. Now, what we learned from this era of COVID, that really the home monitor and care and the focus on service is really very important. And we try to implement more and recruit more patients with the devices as well. Not only a reveal link, that we get a pacemaker, the Micra, the CRTs, and so on for the focus on service. We have them on the home monitor, but we need to add them on focus on, because that will help us in triaging patients, getting patients into the appropriate management in appropriate way. Now we are planning to get more, recruit more companies as well and providers. But as Sophia mentioned a while ago, if you have a lot of these kind of home monitoring from different providers, that you are gonna face a significant problem in terms of the different websites and different data transmissions, different problems with the transmissions. And all of these challenges has to be encountered and appropriately dealt with. The data security, the data accuracy, the real-time access to data, because sometimes you don't have the real-time access. And system integration. System integration has a lot of things all integrated together. The patient, the device, the home monitoring software, the hardware, the software, the net providers, so the hospital information system. So all of these things has to be connected to each other. The cost of the service is another major issue, and it should continue to have a major issue to different hospitals, to different countries, because different countries has a different deal with these kind of costs. Is it added to the device? Is it added as a service? Is it a free of charge? Things that can be added to the devices or to the complementary to the hospital. We know that it is a costly service, so we need to really think about it seriously. Now, I learned during this period, we expand our service with our patients in terms of the home monitor, and we try to get more questions from our patient, including what is the remote monitoring and why do I need it, and what kind of data is being collected, and who's going to process it, who's responsible for the collection and processing of data, who can access my data, and who is the contact person whom I can contact, and can I contact the 24 hours or somebody who's responsible for that. The cybersecurity is another issue that a lot of people are really asking, and a lot of people are talking about hacking devices and interrogating the programming and so on. But still now there is no problem with the cybersecurity so far. The disconnection of bedside monitoring is another major issue that we are facing, especially at the beginning of our experience. In 2015, 17, 18, we had a lot of disconnected bedside monitors. When we established our service and we got somebody who's really dedicated for that service, then we get less disconnected monitors, in which more important communication with the patients and tell them the importance of getting these kind of bedside monitoring to be kept on and so on. Now, another problem is going to be faced in the future, because all of these hardware probably is going to disappear. And most of the companies are going to depend on Bluetooth enabled devices that needs only the mobile application and the patient's own mobile, basically to transmit the data. And that will be probably a problem to an elderly people that might not be able to deal with these kind of applications. Now, in addition to that, other problems that we are facing is just to connect these kind of data automatically to the hospital information system, and especially if the hospital has a special systems that collect the data for the devices, like the Disconnection. The software from Medtronic that can deal and collect data from all providers, from Boston, from Abbott, from Biotronic, from whatever device, that can get the informations and will be transmitted to the hospital information system. But how to connect the CareLink and the focus on data directly to the Disconnection, this is a problem in terms of getting duplicates, getting problem with the matching the numbers of the patients and the data duplication and so on. We are trying in our virtual clinic to minimize our action plan, less than 48 hours in terms of getting the patients as early as possible to get the action appropriately, or at least to deal with the problem, even if we can do it by phone. For example, you increase the medication, you add a dose, you decrease a dose, you just communicate with the patient within a short period of time. So we are trying to get this time as shorter as possible. And we are gonna increase our transmission at least by 25%, probably annually, because if you don't plan yourself, you are gonna face a real problem. As I mentioned earlier, that our transmission, as well as the hospital in-person visit, almost more than 12,000 last year only. If we increase by 25%, means that we are gonna face 16,000, then 20,000, then again more numbers, then be really difficult to deal with the gush of data that you are gonna get. So therefore, you need the focus on service to help you triaging your patient as well. Now, the last thing to mention is the CareLink Express mobile application. This we just implemented recently, that might help in getting the interrogation by somebody who's not expert. So any physician, any technician, any nurse can get this device in a certain area, for example, in emergency, and you can get the patient interrogated just via Bluetooth header connected to the iPad, and this information will be sent directly to the CareLink and can be accessed by a physician from anywhere in the world, basically, and can give the advice as needed. So I will stop at this stage, and I'm happy to take any questions.
Thank you very much, Dr. Ahmad, for this great review for our local experience and your great hospital. I have a couple of questions. Since this COVID-19 expedited and accelerated all these virtual clinics, and it's a successful experience at your center, do you think, hello?
Yes, yeah.
Do you think you will continue to adopt the same virtual clinic experience after the COVID-19 ends at the same rate?
Well, we are trying to get even more, actually. So as I mentioned earlier, that we are planning to get 25% increment annually to get more adoption for this service, and to train more people. And we have only, so far, we have only one dedicated technician from our technicians to deal with this problem. We do have another technicians as for the inpatients, hospital inpatients, the cath lab, the EP lab, the pacemaker clinic, but the one who's really dealing directly with the virtual clinic is just only one, and we're getting another one soon, hopefully. So definitely that will be one of our plans to adopt it in the coming.
And I think it will be a very nice thing to help other centers as well to you who don't use CareLink now or remote monitoring with maybe materials, with the help of maybe Saudi Heart and the companies, to give more teaching materials to the patients, to the physicians, pathways for implementation as well. In your experience, how easy was it to teach our patient population about remote monitoring and to deal with this technology?
Well, it took us almost 3 years to really establish this. So first of all, and I think establish the home monitor is not as easy as people think. It's because it has a lot of factors: the patient's factors, the physicians, the hospitals, the device, the company, providers, the focus on the. It's really a lot of things that you have to put all together. So we found that the first 2 to 3 years, we were not really looking that much. We were giving the patients the home monitor device, but we were not following them ourselves appropriately. So we found that a lot of disconnected devices that doesn't transmit, of course. But after a while, we thought that this is really needs to be tackled appropriately. So we started to look into it more detailed in 2018. Then 2019, we established our service, and we know how much we have patients active, we have how much been disconnected, and we are going to make it more formal. And one of the things that we are thinking about is just to get even a consent for the patient, or creating a consent for the patient. For even the data transmission, as earlier question by Dr. Naeem regarding who owns the data, how can I get my data, and so on. So one of the things that we are talking about is getting consent for the device to be on all the time. Otherwise, there is no need to enroll you in the home monitor. That's it.
That's great. That's great. I'll open the floor for any of my colleagues if they have any questions.
I do have one, Dr. Atif. Yeah. Dr. Faqih, thank you so much for your presentation. Is it easy, from your experience, to get in contact with your patients for any abnormalities that you found through the CareLink? I know there is difficulties, but how was your experience here in Saudi?
Well, as earlier I said, that was a bit difficult in the initial phase, but when they get into the technicians, if you dedicate one mobile that will contact them all the time, they get used to it. They get some kind of relation with the person who's really relaying the information to them, because you have only 1 or 2 persons that are communicating with the patient. You don't have a lot of people. So they know that the phone number that is calling them, that this is the hospital phone number. They accept whatever they got. And sometimes they were surprised that we get some kind of information, like, for example, a pause or a syncope happened because of pause. We asked the patient, did he have a syncope? Yeah, well, I have it. How did you know that I had it? It's based on the home monitor. A problem with the leads, for example, the inappropriate shocks. And some of the patients has shocks while sleeping. They don't know about it. So they accept this in a nice way, but provided that you have a certain person to communicate with them, so they knows who's communicating with them.
That's great. That's great. Any further questions? So if no further questions, I would like to thank you, Dr. Ahmed, for this elegant talk. And at the end, I want to thank all our attendees for attending this event, and I hope it was useful and enjoyable. I would like to thank our esteemed speakers for their elegant talks and extensive review, our esteemed panel for moderating the sessions and the questions. And I would like to thank the Saudi Heart Rhythm and Medtronic for the sponsorship. And I wish everyone a great evening. Thank you very much.
Thank you. Thank you. Bye. Sorry.
Thank you.
Bye-bye. Sorry.